Welcome to the American Heart Association's Advanced Cardiovascular Life Support Update course. In this science overview video, you'll be presented with the most recent recommendations on cardiovascular care based on the latest scientific studies. In the next few minutes, we'll outline the changes in the 2010 American Heart Association guidelines for emergency cardiovascular care and continue to emphasize some of the core recommendations from the 2005 guidelines. These guidelines were produced after an exhaustive review of thousands of peer-reviewed publications. We'll approach these changes systematically by first reviewing changes to basic life support, or BLS guidelines, followed by the newest recommendations for advanced cardiovascular life support, or ACLS guidelines. The steps in the BLS survey for healthcare providers have changed. Instead of the familiar steps of A, B, C, D, where clearing the airway and breathing come before chest compressions now take priority for the unresponsive arrest patient. The guidelines now recommend delivering chest compressions first, before clearing the airway and giving ventilations. The American Heart Association removed look, listen, and feel for breathing and giving 2 rescue breaths from the initial assessment entirely. So, the BLS survey now includes these 4 steps. Step 1. Check for responsiveness. Tap and shout, "Are you all right?" and scan the chest for movement. Step 2. Activate the emergency response system and get an AED. Step 3. Circulation. Check the carotid pulse. If you find a pulse, support the patient with rescue breathing once every 5 to 6 seconds. If you cannot feel a pulse within 10 seconds, initiate CPR by giving 30 chest compressions followed by 2 ventilations. Do not spend more than 10 seconds checking for a pulse. Step 4. Defibrillation. As soon as possible, connect an AED or defibrillator and, if indicated, deliver a shock. Why was it necessary to change these familiar steps? The majority of adult sudden cardiac arrest patients have VF or pulseless VT rhythm. The heart is quivering but not effectively pumping blood to vital organs. These patients have a much higher survival rate if they receive immediate chest compressions and early defibrillations. The ABCD sequence often delayed chest compressions as the healthcare provider tried to open the airway and deliver ventilations. By changing the sequence and giving chest compressions first, more patients may achieve return of spontaneous circulation, or ROSC. However, there are cases where healthcare providers should tailor the sequence of rescue actions to fit the most likely cause of arrest. For example, in the case of a drowning victim or other instances where hypoxia is the likely cause of the cardiac arrest, the priority would be to provide rescue breathing. High-quality chest compressions were emphasized in the 2005 guidelines. The American Heart Association continues to place a strong emphasis on high-quality CPR. This is indicated by a rate of at least 100 chest compressions per minute, a compression depth of at least 2 inches in adults, allowing complete chest recoil after each compression, switching rescuers every 2 minutes, minimizing interruptions in compressions, and avoiding hyperventilation.